Okay, good morning, everyone. Thank you for joining us. I have the pleasure of introducing our speaker, Dr. Torres. Dr. Torres has served as the medical director of the pediatric programs at the partnership at Nemours Children's Hospital, works as a pediatric intensivist in hospital at some of the community partnership hospitals. He's a pediatrician certified by the American Board of Pediatrics to practice pediatric critical care. He brings over 30 years of critical care experience. I've had the pleasure of knowing him for over 20 of those and still enjoy talking to him. Dr. Torres has also served as pediatric consultant on the board of medical directors at Air Life Team since 2008. As well as he's been medical director of the Peds ICU at Lakeland Regional Health Center since 2017. Dr. Torres was recently added to the nationally published list of best doctors in America in 2019. And he will begin it here shortly. Also, if you have any questions, please ask them in the Q&A section below. We will monitor those questions and we will answer them at a later time during the presentation. So please welcome Dr. Torres.
Thanks, Tom. So I'm going to spend the next 20 minutes. Thank you all for joining and taking time out of your busy day. We're going to talk about the importance of mucus clearance in your patients with an impaired cough, why there is a lack of efficacy of manual techniques, especially in hospitalized patients, the Darther shortage of strong evidence supporting mechanical devices, and the in vitro evidence that supports IPV as superior in mucus clearance. Next slide, please. So in the literature, many folks use the words chest physiotherapy interchangeably with airway clearance therapy. However, many of us, myself included, think of the manual techniques when someone says chest PT. But keep in mind that throughout the literature, chest physiotherapy or chest PT is often interchanged with airway clearance therapy. The manual techniques, postural drainage, clapping, percussions, vibrations, certainly have been studied, and we'll get into some of those studies. The important thing is to note that the intensity and the duration of the therapy really varies from person to person. And so it's difficult to maintain consistency in the delivery of these manual techniques, especially in study situations. Imagine in your own ICU or hospital patients how it varies from therapist to therapist. And also included in chest PT are breathing techniques or exercises which are difficult to learn, require concentration, so often are not feasible in children or ICU patients for that matter. Oscillatory positive and expiratory pressure, you're familiar with the a cappella device, active cycle of breathing techniques, forced expiratory techniques, autogenic drainage. We'll talk a little more later. But these techniques are really not as well studied as the manual techniques, and certainly nowhere near as well studied as the mechanical techniques. Next slide, please. So it's been 8 years since the American Academy of Respiratory Care released this clinical practice guideline on the effectiveness of airway clearance therapies in hospitalized patients. And essentially, they recommend cough assist techniques in patients with neuromuscular disease, particularly when their peak flows are low or less than 270 liters per minute. They do go on to say that chest PT, PEP, intrapulmonary percussive ventilation or IPV, high frequency chest wall compression, are not recommended due to insufficient evidence. And I think that probably the next iteration of this guideline will probably be very similar in its recommendations based on the little bit of literature that's out there. Next slide. So why do our patients have a poor cough? Why don't they have good cough? Well, laying around in a hospital bed leads to muscle weakness from muscle atrophy. Neuromuscular blocking agents can certainly lead to muscular weakness. Fatigue, over-sedation are certainly issues in both pediatric and adult ICUs. We deal with increased muscle tone in children with cerebral palsy. The endotracheal or tracheostomy tube themselves can impede the ability to generate a strong cough. Neuromuscular scoliosis can lead to abnormalities of the airway, making it difficult, even in the child with a normal cough, to remove mucus from the lung. And of course, a lot of conditions that we deal with lead to increased secretions and sometimes increased thickness of those secretions. Next slide, please. So obviously, we all want to avoid these complications in our patients. So it's important that we do approach these patients who have impaired coughs with an individualized approach to their airway clearance when they do have an impaired cough. Next slide, please. Before we jump into the literature, Dr. Schechter, who is a professor of pediatrics and a pulmonologist at Children's Hospital Richmond, I loved his definition of efficacy being an article of faith, backed by clinical experience, which most of you have, and moderately convincing, but by no means definitive evidence. And that's very true. Next slide. But in some situations like chest PT and bronchiolitis, there's certainly been sufficient evidence to say that there's really no benefit. And out of 1,249 infants that have been studied in a combination of 12 randomized controlled trials, despite there being all these different techniques examined, there was, besides no change in the parental impression, there were no change in outcomes. And one study of a forced expiratory technique that had close to 500 patients in it, in fact, found an increased risk of vomiting and respiratory deterioration when forced passive expiratory technique was used. So clearly no benefit, and in some cases harm. So we should not be doing manual techniques in this population for sure. And there's very little evidence that manual techniques work in other conditions either. Next slide. This is the only randomized controlled trial I could find of chest physiotherapy in hospitalized patients with community-acquired pneumonia out of Brazil, where they looked at manual thoracic vibration, positive end expiratory pressure, artificially stimulated cough and suctioning in greater than 5-year-olds, and also encouraged them to force exhale with their glottis open versus just taking deep breaths and asking them to cough intermittently in the control group. And they just looked at whether their respiratory illness score improved. And what they found was that there was really no difference between the two groups at baseline, although the group that received chest physiotherapy had slightly more pleural effusion. So you could say maybe their pneumonia was a little more complicated, but nevertheless, the outcomes were no different. So clearly, chest physiotherapy has not been shown to work as manual techniques in community-acquired pneumonia. Next slide. So that brings us to the mechanical devices that have made their way into our practices in hospital medicine. And these devices, I'm going to go into each one, but before we do that, I'd like to take a poll to see how many of you have used these devices. So please select the ones that you have used in your own practice, and that way we can see how widespread these are amongst all of you. Take a few seconds here to get this poll. Many of you may know the mechanical insufflator, exsufflator as a cough assist. which is, I think, the only manufactured device, in case you didn't recognize it by that name. All right. So it looks like many of you are users of IPV, CPEP, and continuous high flow oscillation, high frequency chest wall compression, and mechanical insufflator exsufflator. So great. Next slide, please. There we go. Thank you. So, like I said, the Cough Assist by Philips is the only manufactured device that uses this approach. It's primarily prescribed in patients with neuromuscular weakness. Next slide. It's well tolerated by these patients with neuromuscular weakness, increases their peak cough load. Many of them use it at home as maintenance therapy. You can adjust the inspiratory and expiratory pressures. You can do it manually or automatically. Very little risk of complications and can be delivered through many interfaces. The disadvantages, however, are that patients with airway collapse, which we have in some of our younger pediatric patients, doesn't work very well. We try to avoid it in patients with recurrent pneumothorax. If you have a patient with muscular dystrophy who's late stage and has cardiomyopathy, it may cause arrhythmia in that population. That's been reported in a couple of cases. But other than that, it's fairly safe. The only problem is we don't have much proof of efficacy in other diseases. The high frequency chest wall compression, most of you, I know in my world, they call it the vest, but it is also manufactured by Philips called Encourage and by Electromed called Smart Vest. All these devices work by inflating a vest that's worn by the patient and deflating it at different frequencies to supposedly decrease the viscoelasticity of the secretions so they're less adherent to the airway walls. It's well tolerated. In fact, I've seen some of my kids fall asleep with it on. Comes in many shapes and sizes. There's a case series of children with trachs having increased secretion removal with it. However, disadvantages are really doesn't bring the secretions all the way up and out. So some patient has to have a cough or have some way of having their airway suctioned. Primarily been studied in cystic fibrosis patients. We don't know what age, how young can you use it in, and certainly we are aware of, or at least cautious with our premature infants because of their susceptibility to neurologic injury and certainly the possibility of rib damage. The next device is the Velara or MetaNeb by Hillrom, which delivers continuous positive end expiratory pressure alternating with continuous high flow oscillation. As you can see on the screen of the Velara, you get 2.5 minutes of positive pressure continuously to maintain airway patency. And then, of course, 2.5 minutes of continuous high flow oscillation to try to remove secretions. And that goes on for a total of 10 minutes per treatment. There is a 10-minute treatment time. You can deliver an aerosol during the treatment. There's a lung inflation therapy option to prevent and treat atelectasis, can add inline to the ventilator, and is a single patient use disposable circuit. But again, we lack studies to support the use of this in hospitalized patients. Intrapulmonary percussive ventilation, which many of you seem to have used, is a pneumatic device that's been around for some time that delivers high frequency percussive pulses to the lungs at rate of 60 to 330 breaths per minute and can deliver an aerosol simultaneously with the IPV2C. Advantages is it can be used via multiple interfaces. You can use it in premature infants in the NICU and in the largest adult patients in the adult ICUs. It's safe, well tolerated. It's a pneumatic device, so it doesn't really require electricity and really has no known contraindications. Again, there's still a lack of adequate studies. This was an interesting study that I just recently discovered, although it's from 2017 out of Belgium, where they compared a breathing technique called assisted autogenic drainage delivered for 20 minutes. And they describe it as a gentle increase in manual pressure on the chest during inspiration to guide breathing towards a desired lung level. That's the best I could do. I couldn't find anything else in the article to describe it. IPV was used as standard, again, 20 minutes. The interesting thing was for the infants to tolerate either of these techniques, and in the control group, they would sit on a exercise ball, Swiss ball, where they would bounce up and down while holding the child on the ball between their legs to get the patient to tolerate the treatment. So they bounced with the breathing technique, IPV, and neither in the control group. And so there were 31 infants in each group, and there were no complications reported. And the two groups, the two treatment groups, actually had a significant decrease in their length of stay, although the length of stay of the control group is a little prolonged in Belgium. And I'm not sure that we would get consent to bounce babies on a ball in the US, but it's an interesting approach to getting babies to tolerate therapy. Next slide, please. In adults, this was a study that compared IPV to manual techniques twice a day using IPV and chest PT, and then there were 40 controls. They did show an improvement in ventilation and oxygenation. And in the table, you can see that the amount of time on the ventilator and the length of stay in the ICU were both reduced with the IPV group over the chest PT and control group. So this slide will demonstrate to you that there's mucus at one end near the simulated lung. And the reason I show this video is because not only can you see IPV moving the mucus across towards the IPV machine, but there's such a thing as mucus velocity. So how quickly does the IPV move this mucus from one end of the tube to the other? And this was a abstract that was presented at the AARC a couple of years ago. Is published in Respiratory Care in abstract form, where they put mucus at one end near the lung and then measured how quickly it moved across the endotracheal tube over 2 minutes. And they compared the IPV versus metaneb at the highest frequency, which we could assume is about 330 breaths per minute. The mucus moved at 4 centimeters per minute in the lowest frequency for IPV, which was, I assume, 60 breaths per minute. It actually moved in the opposite direction, 1 centimeter per minute. The meta-neb in both high and low frequency did not move the mucus at all. So this was one in vitro study comparing CPEP CHFO to IPV in terms of mucus velocity. The next video actually shows a setup of a Velara and IPV to show you how much mucus can be removed from a lung, and in this case, it's a balloon, using the two devices. So I'm going to play this, and please pay attention to the to how the setup is in particular, because I'll talk about a study afterwards. Not sure you could hear the volume. No volume. That's okay. You could see the setup there. On the one side, to his left, is the IPV machine. Balloon at the end is filled with mucus, and then that's attached to an endotracheal tube. Here he's actually showing you the meta-neb, and it's attached to the endotracheal tube on the proximal end, and the video's not moving, but oh, there we go. You can see the oscillations, but really not much happening as far as mucus coming from the tube. There you go. Now we hear it.
And now let's try the IPV.
So thank you, Ellen. I have a respiratory therapist that I work with at Nemours who conducted this very same in vitro study, placing mucus in a balloon attached to a 7.5 French endotracheal tube, and instead of the meta-neb, used the Velara with those settings compared to the IPV2C with those settings, and did with and without ventilator for 10-minute cycles. And basically what he showed was that the IPV clearly removed a greater portion of the mucus from the balloon after 10 minutes than the Velara did in either instance, with or without the ventilator. This is going to be presented at the AARC in Arizona next month. So, and will then be published in abstract form in Respiratory Care. So hopefully if you attend the AARC, you'll say hi to David Kahneman for me and thank him for sharing the results of his study with us. But I think it clearly shows that you can remove more mucus with the IPV2C than CPEP CHFO. Now, we've known for a long time that RT-driven protocols in the delivery of beta agonists or mechanical ventilator weaning reduces length of ventilation and length of stay in the ICU. But my friends at Arkansas Children's Hospital did a before and after when they changed their protocols to include airway clearance therapy and let the respiratory therapist determine as to when to reduce the frequency and discontinuation of airway clearance, as well as beta agonists. And as we've seen in multiple studies, there was a significant reduction in the number of treatments, ventilator days, and length of stay by a minimum of 15% and as much as a third. So clearly giving the bedside clinicians the ability to drive not only administration, but discontinuation of this therapy leads to better outcomes. So that's all I have. It took a little bit more than 20 minutes. I apologize for that. And I will take questions at this time.
Great. If anyone has any questions, you can please put them in the Q&A at the bottom of the screen. At this time, we don't have any questions. Everyone must know everything that you said.
Well, you know, one thing, Tom, that I didn't talk about, if we have a minute or two here, is the combination of mechanical techniques. I've seen this happening more and more, especially when children are getting the high frequency chest wall compression and they come into the hospital. Often the IPV will be added and the frequency of the delivery of both will be increased depending on the acuity of the patient. But that's something that certainly there's been no study of that in the literature.
Yeah, that's you see some stuff with taking the cough assist or whatever and adding maybe or adding cough assist to the vest to help supplement a weak cough after the secretion, but you don't see much about the escalation. And that's part of the admission process, is evaluating the patient and decide whether to continue the therapy they're on, or we need to escalate it to something that's going to be a little more effective for that patient. We do have a question here about describing the physiology of the IPV.
Yeah, so that's a great question. And certainly, we don't have a lot of time to get into the physics, but clearly the high frequency percussive pulses of air create both convective and diffusive flow. And I like to think of it as when you got a cup of coffee that's full and you're dripping some more into the center of the cup. Imagine every time you drop a little into the cup, a little comes up the sides and over the edge. And so if you sped that up and did that 300 times a minute, as you're pushing air in, air is coming out simultaneously and bringing with it mucus. And certainly, if you want to see visual graphics of that, you can certainly visit the Percussion Air website where you can see it in action.
Perfect. Thank you. I don't see another. I do see someone just typed no volume, but I'm not sure. Oh, they couldn't hear the video. I'm sorry. But yeah, so that is our only question at this time. So we appreciate everyone's time. If no one has any additional questions, we can end this video.
Hi, Chris. I guess they had a Chris Lowry there.
Oh, yeah. Said hi.
So, Tom, we do have a couple questions that came in through the Q&A side. The first one here was the therapist-driven protocol in critical care only?
Yes.
And then another one, is there a billing code for insurance companies to pay for home use in the adult patient?
Don't know the answer to that one.
There is a HCPCS code for it. And the insurance will really dictate whether or not, usually with support of letters of necessity, and that we've usually been pretty successful with getting approval, except for most Medicare patients. Private insurance and public aid, we've been able to get approval on those patients with letter of necessity from the physician.
Run out of time.
Okay.
Yeah, thank you, everybody.
All right. We appreciate it. Thank you for attending.